Welcome to the AstraCura Medical Series. This briefing focuses on the clinical management and treatment pathways for high-risk neuroblastoma. Neuroblastoma originates within the sympathetic ganglia chain located along the spine. This visualization shows how the hypervascularized mass exerts significant mechanical pressure against adjacent structures. For pediatricians and neurologists, identifying this mass effect is the first diagnostic priority. As the tumor grows, it frequently exerts direct physical pressure on the renal structures. Upon palpation, the clinical presentation typically involves a large protruding mass. In high-risk cases, these tumors are often of such a size that they are initially unresectable through surgery. Despite the application of multimodal care, high-risk neuroblastoma remains largely chemorefractory. These tumors frequently resist initial treatment cycles, resulting in a poor overall prognosis for the patient. To address this resistance, we must utilize a rigid, time-sensitive multimodality sequence. This briefing maps the specific clinical steps required to intervene in these high-risk cases. Salvaging a patient's prognosis requires moving beyond isolated interventions and committing to a highly coordinated, sequentially dependent treatment pipeline. Before initiating any therapeutic intervention, the clinical pathway is divided through immediate risk stratification. This initial node involves screening for specific genomic markers, MYCN amplification, 1p deletion, and 11q aberrations. Identifying these markers is the non-negotiable first step of the protocol. Stratifying low and intermediate risk patients allows the clinical team to avoid the toxic side effects of intensive chemotherapy, as these cases do not require the most aggressive interventions. Patients presenting with high-risk markers, however, are immediately moved into the maximum intensity multimodality pipeline. Once high-risk status is confirmed, it is necessary to provide the family with a realistic assessment of the prognosis and the physical demands of the treatment sequence ahead. This genomic stratification is the primary operational mechanism of the treatment plan, dictating the intensity and the trajectory of every subsequent clinical intervention. The second node, induction and local control, begins with 4 to 6 cycles of intensive chemotherapy. This stage is designed to reduce the tumor's volume through repeated cycles of high-intensity induction. The clinical goal of this induction phase is to convert a massive, unresectable tumor into a surgically viable target for the medical team. Following this reduction, specialized pediatric surgeons perform the physical resection of the residual tumor mass. This resection involves significant anatomical complexity, as the surgeon must navigate around and detach the tumor from compressed renal and spinal structures. While induction and resection successfully address the primary tumor mass, they only provide local control. To address the microscopic systemic cells that remain, the clinical pipeline must move into its next phase. We move now to the third node, precision radiotherapy. The timing of this intervention is a primary driver of the patient's overall prognosis. The clinician must determine the exact window for recovery following surgery before the patient can safely begin radiation protocols. The standard protocol involves delivering approximately 24 gray to the immediate tumor bed in a strictly controlled fashion. This dosage is calibrated to be high enough to eliminate microscopic remnants, but constrained enough to prevent a precipitous drop in the patient's blood counts. Radiation is a mandatory step used to achieve local sterilization. This dosage must be high enough to clear the tumor bed, but carefully limited to preserve the patient's physical resilience before the most toxic phase of treatment begins. Remaining neuroblastoma cells are highly chemorefractory and require lethal, high-dose myeloablative chemotherapy for complete eradication. Delivering these doses would normally result in fatal, irreversible aplasia, creating a clear biological limit to standard chemotherapy. To bypass this limit, we utilize the fourth node, autologous consolidation. This involves the collection and storage of the patient's own stem cells prior to the high-dose chemical sweep. Once the chemotherapy has cleared the remaining tumor cells, the stored stem cells are reintroduced to rebuild the patient's immune and hematopoietic systems. In some high-risk cases, this node requires a tandem approach of 2 consecutive transplants, necessitating 2 to 3 weeks of specialized care in a transplant unit. The stem cell transplant serves as a rescue protocol. By rebuilding the hematopoietic system, it provides the physiological runway required to deliver the highest possible doses of chemotherapy directly to the remaining neuroblastoma cells. For patients who complete the consolidation regimens, we enter the final node, immunotherapy and maintenance. This phase utilizes dinutuximab, an anti-GD2 antibody, to improve long-term survival by targeting residual disease at the molecular level. In cases where the disease remains persistent or recurs, MIBG therapy provides a targeted radiopharmaceutical option for salvage. These final targeted modalities act as a molecular sweep, addressing the chemo-resistant remnants that survive the earlier phases of treatment. This complete pipeline demonstrates the complexity required to treat high-risk disease. Managing these cases requires constant coordination across multiple medical specialties. Foundational steps, including early diagnosis, genomic stratification, and initial chemotherapy titration, can be managed safely at the local level under expert supervision. However, when a case progresses to precision radiation, complex vascular resection, or tandem autologous stem cell transplantation, the requirements of the protocol often exceed local capacity. These high-intensity nodes require immediate referral to advanced specialized centers, such as Apollo hospitals in India. AstraCura partners with local clinicians to bridge this gap, managing the transition from local chemotherapy to international specialized modalities. Integrating local pediatric expertise with rapid specialized referral allows for clinical outcomes that chemotherapy alone cannot achieve. To begin collaborative case management or protocol titration, contact the AstraCura team today.